In cardiomyopathy, we can divide this into three main categories: dilated cardiomyopathy, hypertrophic, and restrictive. The most common of the cardiomyopathy is dilated cardiomyopathy, in which case 90% of your questions will likely come from here. Let's talk about that first. In dilated, the etiology is that there's a lot of things that may cause dilated cardiomyopathy. In most cases, it's idiopathic. We say there's a strong genetic mutation component to this, and then we have some other things that are caused by the person or by the hospital whatsoever. Alcohol is extremely important. As you can see, there's a star here. Viral myocarditis can cause this. Physiologic changes in pregnancy can cause dilated cardiomyopathy, and drugs and other toxins. Let's talk about alcohol first. In the case of alcohol, alcohol will cause B12 and thiamine deficiency, and because of that, that may precipitate dilated cardiomyopathy. The key reason why I put a star to alcohol here is because it is one of the only toxins on the heart that causes dilated cardiomyopathy that is reversible. This is a very, very high yield question. You either see this on your board or you also see this on your Q banks. The next one is viral myocarditis. This one has to do with Coxsackie B virus, which most frequently also appear on exam. Watch out for a person who presents with these vague signs and symptoms with chest x-ray showing an enlarged heart. Pregnancy is another thing that may cause dilated cardiomyopathy. Again, this is a physiologic response to the pregnancy, and individuals who are pregnant will have hypertension, they may have nutritional deficiency, which may precipitate dilated cardiomyopathy. Drugs and toxins are very important. You have doxorubicin, you have cocaine, and you have cyclophosphamide, or other things that may cause dilated cardiomyopathy. Clinical presentation: in dilated cardiomyopathy, the individual may have both systolic and diastolic dysfunction. Causes of systolic dysfunction simply means that there's a failure to contract. Something is making it harder for the heart to contract. And in diastolic dysfunction, the heart may have fibrosis, and of course, the profound dilation may prevent adequate filling of the heart. Diagnosis: essentially, you can do a chest x-ray, EKG, or echocardiogram. Chest x-ray will show you an enlarged cardiac silhouette, all right? And you may also see what is called the curly bead lines in pulmonary section on the chest x-ray, especially at the peripheral. In the EKG, you may see signs and symptoms of arrhythmia. And of course, on the echocardiogram, you have to choose which one is most superior. You have TEE and you have TTE. In most cases, the TEE is most superior. And that's the gold standard for diagnosing dilated cardiomyopathy. What information it gives you, it shows you the wall motion abnormalities, and it also shows you if there's any kind of a murmur or regurgitation, especially the mitral valves. The treatment plan for dilated cardiomyopathy is important. You can give the individual ACE inhibitors, beta blockers, and spironolactone. We said these three medications in combination are the ones that are life-preserving, hence the green battery here. Then you have digoxin diuretics you can give the individual, especially if the individual is having a lot of regurgitation that goes into their lungs, so they have pulmonary edema and things like that. Then you can also consider giving the person an AICD or some kind of a device when their ejection fraction is less than 35%. This is HOCM, hypertrophic cardiomyopathy. Essentially, the definition is in the name. The individual has a hypertrophic heart. The etiology in this case is mostly autosomal dominant in 60% of the cases. It's due to a defect on chromosome 14. The individual will have very large B myofibers, which will be in complete disarray. So the person may have very, very huge myocyte. In this individual, the pathophysiology is such that they can have a stiffened heart. That's the whole problem here. Hypertrophic cardiomyopathy presents with too much muscles and too much tissue that the heart becomes stiffer. All right. The key reason that the person may have problems is that they may have an enlarged ventricular septum. And in this individual, sometimes they may be asymptomatic, but when the septum gets large enough, it may impede the flow from the left ventricles to the aorta to the systemic circulation, and so that can lead to problems. So here's an image. So this image here is showing you the person has a normal heart here. You can see that the septum here is thinner and the left ventricle is large enough to allow for the blood to flow into the systemic circuit. If you look here, this individual has a HOCM where the ventricles is very thick here, and so that thickness can lead to obstruction of blood flow into the systemic circulation. Hypercontractibility due to the excessive muscle will lead to an increase in the ejection fraction. Recall that normal physiological ejection fraction is about 70%, and in these individuals, they may have an EF of north of 90%. So that tells you that they're having heart problems. It's not likely to be dilated, especially if you see that the ejection fraction is 90%. In a clinical presentation, it's very important to look at your demographic. This usually appears in young people, especially athletes. The individuals may have jugular A wave, they may have S4 gallop, they may have dyspnea on exertion, and this is one of the reasons why a person may have syncope. We talked about etiologies or things that may cause syncope. We said things like aortic stenosis and constriction around the heart and HOCM. So these are the things that may cause syncope. They also may have sudden death because of arrhythmia due to the complete disarray of the myofibers. In terms of the diagnosis for HOCM, you essentially want to do an EKG or an echocardiogram. An EKG can basically show you the person may have pseudo-Q wave in these different leads, V1 to V3. It's not very gold standard. The gold standard here is doing an echocardiogram. For most of the cardiovascular pathology, when in doubt, when you don't know the answer choice, in terms of the diagnostics, echocardiogram should be your default. So you can do an echocardiogram here, and the person may show you motion abnormalities. It may show you mid-systolic closure of the aortic valve. So again, this is something that leads to obstruction of blood flow from the left ventricles to the system circulation. HOCM is important in understanding this exact correlation with athletes and the fact that it's autosomal dominant and the fact that it presents with signs and symptoms of like angina versus syncope. The next one is dealing with restrictive cardiomyopathy. In this case here, you have a complete restriction of the heart, so therefore you can expect that there will be S4 gallop going on here. This is a diastolic process. Recall that diastole is when the heart is relaxing and you allow for blood to flow in it. So if you have a restriction around the heart, it makes it harder. The pathophysiology for restrictive cardiomyopathy is such that the person may have an abnormal relaxation process, so therefore it can impair filling of the heart. Of course, these issues will lead to decrease in compliance, and that leads to the decrease in the diastolic function. The etiology for this is that the person may have a handful of things that may cause this. You have things like endomyocardial fibrosis, which is like secondary to a myocardial infarction. You have low floor syndrome, it's not very high yield, but it's on the list of things that cause restriction around the heart. You have radiation. This is high yield. I give it a star because they will give you a clinical vignette where a person had thyroid cancer at a younger age, maybe at age 30 or something. It was cured with chemo radiation, and then at the age of 50, they present with signs and symptoms of jugular venous distension and a whole lot of other things that looks like they have right heart failure. Well, these individuals have restrictive cardiomyopathy because of the fibrosis. This is a high yield concept to remember. Amyloidosis is another thing that may cause restriction around the heart. And the next one is hemochromatosis. Hemochromatosis is something that may come with other slew of signs and symptoms like joint pain, signs and symptoms of diabetes, which is called Brown's diabetes. And the heart problem is what we're describing here, which is the restriction around the heart. Then you have metastatic tumor, which is very rare, but it may cause restriction around the heart. Clinical presentation for restrictive heart disease, individual presents with chest pain, jugular venous distension. They have an S4 and S3 gallop, dyspnea, fatigue, all those signs and symptoms that presents when the person has either a restriction or dilation of the heart. In diagnosis, you essentially can do the three modalities, the X-ray, the EKG, and echo. Again, when you are confused or you don't know what to pick specifically, echocardiogram is your default. And when you want to specify which one, the TEE should be your default of choice. Let's look at the X-ray. On the chest X-ray, the person may present with cardiomegaly, and they may present with signs and symptoms of pulmonary congestion. EKG may show signs and symptoms of low voltage in the amplitudes of the QRS complex. So if we look here, you can see the QRS complex. So everything looks kind of normal. Nothing looks too crazy here, but the amplitude, it's low. The amplitude should be a little bit longer than this. It should be a little bit longer than this. And so when there's low voltage, you know that there's something impeding the electrical signal that should be, gathered by the leads and such. You also see such a EKG on a person who is obese, and you're trying to do an EKG on them. The gold standard here is echocardiogram. We said that in doing echo, you will see a thick wall, and then you may see myocardial textures and stuff. Depending on the etiology of this restrictive cardiomyopathy, cases like amyloidosis will give you different presentation on the echocardiogram. Again, just remember, we say that whenever you are unsure of the next best step in terms of the diagnosis of most of the cardiovascular problems, you may want to consider echocardiogram. Specifically, a TEE is superior to a TTE. The treatment for restrictive cardiomyopathy is essentially a heart transplant. There's not much you can do about this. You have to consider heart transplant. This is cardiomyopathy.